there have been a tremendous progress in the treatment of heart failure in the last 5 decades. 5 decades back, there was nothing to treat heart failure, maybe mercurial diuretics, rest. Heart failure means rest and death. But we have made tremendous inroads into the progress of heart failure treatment by which we could reduce the mortality to around 10 or 13%. Means up to 10 or 13%. But still, it's a disease with high mortality. It's a disease with high morbidity. It's a disease where we lose patients, at least 50% of the patients in 3 or 5 years of time, and a rehospitalization of almost 50% in a year time, 25% rehospitalization in 1 month. So how do I treat heart failure with preserved ejection fraction in 2023? This is, reduced ejection fraction. This is the reduced ejection fraction. You can see this patient, all the cardiac chambers are enlarged. The LV hardly contracts. And if you look at the ejection fraction, by the 3D ejection fraction, it's 10.75%, close to 10%. High LV filling pressures, moderate mitral regurgitation. And this is the prototype of heart failure with reduced ejection fraction. But this alone is not sufficient to diagnose it. There should be signs and symptoms of heart failure, a structural or a functional cardiac abnormality. A structural abnormality means an abnormal cardiac enlargement, a chamber enlargement, moderate to severe ventricular hypertrophy, or moderate to severe valve lesion. And objective evidence of pulmonary venous congestion, systemic venous congestion, elevated BNB or NT-proBNP, either of these two things, either evidence of pulmonary venous congestion or systemic venous congestion, or elevated NT-proBNP or BNP. And the cutoff value is for ambulatory patients in the NT-proBNP of 125, and for a hospitalized patient, it is 300. That's how you diagnose this condition. And the treatment goals are decongestion, reduce the mortality, reduce the heart failure admissions or emergency room visits, better quality of life, and of course, avoid drug-related problems with organ protection, basically kidney protection. So the patients are with heart failure and reduced ejection fraction, when they become highly volume retention, there's this huge volume retention, significant congestion. It's systemic venous congestion and pulmonary venous congestion. So most important first treatment goal is to avoid get rid of this congestion, both the systemic venous congestion as well as the pulmonary venous congestion. They'll have elevated ECF volume, elevated intracardiac filling pressure, pulmonary venous congestion, systemic venous congestion, and their symptoms are due to these things: dyspnea, edema, PND, and orthopnea. So first, tackle this. Patient should become less symptomatic. And also, if the congestion persists, it can go on, it can lead on to significant end-organ damage, and they'll reach a point of no return. So we have to aggressively treat the congestion. As you are all aware, the drug of choice is loop diuretics, either a furosemide or torsemide. These are the two loop diuretics available with us. And it's a class 1 indication to relieve congestion and improve symptoms and prevent worsening. There is a change in the concept of reducing congestion or decongestive therapy. Previously, it was all, you give some amount of Lasix, see what is the response, whether the patient improves, add further dose of Lasix or torsemide. But now we have objective evaluation and objective parameters by which you can guide on therapy. And 2 objective parameters basically we look at. One is the urinary spot sodium, that is adequate diuresis means there should be at least urinary spot sodium of 50 millimoles per liter, that we look at after 6 hours of giving an intravenous diuretic. And urinary volume at 2 hours, there should be at least 100 to 150 ml per hour urinary output. If this is not achieved, we have to increase the dose of diuretic, preferably double the dose of diuretic, and this may go on till we reach a ceiling dose of 300 milligram of furosemide equivalent. And even then, if we are not reaching the goals, of course other clinical parameters are there, like decrease in the edema, decrease in the weight, decrease in the heart rate, decrease in the respiratory rate, so all these things. But this is the most objective thing that we can look at. If still there is no adequate diuresis, no adequate natriuresis, then you can block the nephron sequentially. From the distal convoluted tubule, add a thiazide diuretic. The collecting duct, add an aldosterone antagonist. And in the proximal convoluted tubule, the SGLT2 inhibitor, or with the current data, we can even use acetazolamide. But in that particular data, SGLT2 inhibitors were not used. And these are the ways by which clinically and investigationally we can look at the congestion. You can look at the NT-proBNP, you can look at the chest X-ray, the venous imaging by using an ultrasound probe, you can look at the IVC congestion, and also pulmonary venous congestion by assessing the ultrasound mediated lung comets it's a simple bedside examination. So diuretic dosage, if it is acute decompensation of patients who are already on diuretics, you can start with a dose of 2.5 times their outpatient dose they were taking. Or if it is a naive patient, start with 20 to 40 milligram of furosemide equivalent. Then the subsequent dose of loop diuretic agent dose is guided by clinical response to initial dose. The first assessment is usually after 2 hours of an intravenous diuretic. Of course, the creatinine will increase. No doubt, the creatinine increase of around 0.5 milligram per deciliter during diuretic treatment is common, and it do not always necessitate stopping or decreasing loop diuretic dosing. Adequate decongestion is extremely important to reduce the renal venous congestion also. So you should not withhold diuresis inappropriately. Inappropriate holding of diuretics has been found to be very common. Adequate decongestion, adequate diuresis, that helps the renal function also. Initially the creatinine may rise, then it will settle. And is it torsemide or furosemide? The Transform-HF randomized clinical trial data published last year, there is no much difference between torsemide and furosemide in case of regarding the hard endpoints like all-cause mortality over 12 months. The mortality reducing drug, from the evolutionary point of view, you can see the first one proven was ACE inhibitor, then a beta blocker, then the mineralocorticoid receptor antagonist, and by that time ARBs also came into the picture in those patients who could not tolerate a ACE inhibitor. Then the last addition was in the paradigm heart failure trial, the ARNI, which has got an edge over ACE inhibitor. But despite the use of ARNI, you should see that there was a 13.3% mortality rate. So these are devices and the newer drugs which came in from 2000 to the 2020, ICD, CRT. Then the paradigm HF, already I've mentioned it, the ARNI in 2014. Dapagliflozin, empagliflozin. So the SGLT2 inhibitors, followed by vericiguat in 2020, and then the Galactic HF trial using omecamtiv mecarbil. So the paradigm heart failure, 20% additional risk reduction over and above that of enalapril. Can we use it in acute heart failure? The Pioneer HF data showed that it can be used in acute heart failure. There is a reduction in the clinical endpoints also, though the study was not statistically powered to detect the reduction in the clinical endpoints. And the transition heart failure trial, they found that it is feasible to start, and at least 50% of the patients could reach a target dose of ARNI in 10 weeks' time. Most important effect of ARNI is that it improves the LV ejection fraction. It reverses the remodeling. The PROVE-HF data, it shows that an average of 10% improvement in the ejection fraction over a period of 1 year. Reduction in the end diastolic volume, reduction in the end systolic volume. And 25%, 1 in 4 could experience an increase in the ejection fraction by 13%. It's an excellent, I think it is one of the extremely good results that we can obtain with a heart failure drug. This patient presented to me in September 2022. At that time, the LV ejection fraction was 17%. Extremely high, the LV filling pressure, E by E prime of 43, NYHA class 4. We can see Hartley contracting ventricle, all the chambers enlarged, severe systemic venous congestion. Medical therapy, beta blocker, ARNI, SGLT2 inhibitor, MRA plus torsemide. And we plan for an ICD if the LV ejection fraction persists below 35%. And in Jan 2023, this is his LV. The LV contracts actively, the size has come down, end diastolic volume came down, end systolic volume came down. The E by E prime is 14 now, significant reduction in the LV filling pressure. The IVC is hardly seen, he is in NYHA class 2, there is no indication for ICD now. So the PROVE-HF data and the paradigm HF data which shows the sudden cardiac death reduction in the paradigm HF data with ARNI. The PRO-HF shows improvement in the ejection fraction. So LVEF improves. With that, the arrhythmic risk comes down. So ARNI may help us to avoid ICDs. There is another paper on it. And in hospital, try if the patient is on other RAS inhibitors or who have already been on other RAS inhibitors, shift to ARNI or initiate ARNI at the time of discharge. The blood pressure should be more than 100 for at least 6 hours, no IV inotropes for last 24 hours, and no increase in the diuretic dose or IV vasodilator in the last 6 hours. These criteria should be fulfilled. The SGLT2 inhibitors, we have data with dapagliflozin, with empagliflozin. And both these data shows it's extremely useful, especially it reduces, the predominant benefit is reduction in the heart failure hospitalization. Additional benefit which is so desirable in heart failure is renal protection. Reduction or deterioration of the renal function can be prevented. In the long run, it reduces all the renal endpoints. And not only that, the benefit comes quite early. A statistically significant benefit, separation of the day curve occur at day 28 with dapagliflozin and by day 12 with empagliflozin. So this is one of the drugs that provides the benefit quite early. And not prescribing SGLT2 inhibitor discharge to an eligible patient exposes him to a statistically and clinically significant excess risk of death and readmission in the first days to weeks post-discharge. Both these drugs are complementary. So this patient, 8 months ago, he presented with anterior wall STEMI. We did a primary angioplasty, but his LV function did not improve. Actually, the LV seems to be non-viable LAD territory, recurrent hospitalization, despite all the 4 therapies, all the 4 foundational therapies. So what we could add was vericiguat, and now he could reach the full dose of vericiguat, 10 milligram OD. Vericiguat, in those patients, symptomatic, despite all the 4 foundational therapies, that is worsening of heart failure, hospital admission, or escalation of the dose of diuretic, reduction in heart failure hospitalization. Or those patients who are unable to tolerate a standard therapy. And heart rate, if it is not controlled with maximum tolerated dose of beta blocker, ivabradine is indicated. And it reduces the risk of rehospitalization during the vulnerable phase. Every patient with heart failure should be evaluated for iron deficiency. And if there is iron deficiency, they should be treated with ferric carboxymaltase, intravenous. So we have all these 7 fantastic drugs: RAS inhibitors, beta blockers, mineralocorticoid receptor antagonists, SGLT2 inhibitor, ivabradine, vericiguat, and omecamtiv. Omecamtiv is yet to be licensed for use. And then device therapy when appropriate, if ICD, if LVF less than 35%, CRT in LBBB, but give adequate time for the LV ejection fraction to improve with medical therapy. Delayed initiation means your patient is unprotected. So sequential uptitration versus simultaneous initiation, it is simultaneous initiation. So appropriate therapy is a golden opportunity in the trajectory of heart failure treatment, guided by blood pressure, heart rate, creatinine, potassium, congestion status, chance of proper follow-up, and finance. Treatment naive patients, these 4 foundational therapy. Already on treatment with quadruple therapy, you continued the treatment, escalate to the maximum tolerated dose, or change like ARB, ACB to ARNI. Add SGLT2 inhibitors, if needed add vericiguat. Look for the scope of hydralazine or nitrate in persistently symptomatic patient. Ivabradine is if indicated, iron studies and ferric carboxymaltase. LBBB, CRT, ICD, mechanical cardiac support, and if required, he should be put in the transplant list. So checklist, optimize medications, discuss the plan, need for device and treatment. The strong HF data presented some 2 months ago, they found that you can start the treatment with all 4 agents before discharge and try to escalate it to the maximum tolerated dose or guideline recommended doses in 2 weeks of time. 50% can achieve it, and there is a benefit. And immediately after discharge or starting treatment, frequent follow-ups during the initial period, 1 week, 2 weeks, 3 weeks, 6 weeks. 180 days, there was a benefit. And it was readily accepted. So how do I treat heart failure and reduced ejection fraction in 2023? ARNI, heart failure beta blocker, mineralocorticoid receptor antagonist, SGLT2 on board as early as possible. If possible, at discharge, the patient should be on all these 4 medications if they were admitted with acute heart failure. And frequent follow-up for rapid uptitration in the early phase. I would prefer the first week, second week, third week, and then the sixth week. Vericiguat, if worsening of heart failure with standard therapy, vericiguat is available right now. Correct iron deficiency if they are with ferric carboxy maltase. Devices when it is appropriate. And if the patient is not improving, deteriorating despite all your gadgets available, medical gadgets available, he should be put on a LVAD and list in the transplant in case of in all refractory heart failures. Thank you.
Yeah, it was an excellent talk. You have covered almost everything. We see most of our patients with heart failure are ischemic cardiomyopathies. So is there any change in those patients when you compare ischemic versus non-ischemic heart failure?
Definitely. If we look in the Kerala heart failure, acute heart failure registry data also, 70% of the patients are ischemic patients. When we compare with the non-ischemic cardiomyopathies, the non-ischemic patients do better than ischemic patients. But even in ischemic patients, in ischemic patients who have a scope for revascularization, they improve in a much better way. In those patients in whom we cannot revascularize, and if it is a non-viable territory, their prognosis and progress of the disease is worse when compared to the non-ischemic cardiomyopathy patients.
Then there was no mention about lanoxin. You think lanoxin is gone out?
No, this also I found it extremely difficult to contain it within the time provided of 15 minutes, and I have overshot the time. Digoxin, the current indication for digitalis is patients who are not responding to the standard medication, still symptomatic. Second, those patients with atrial fibrillation whose heart rate control is difficult with a beta blocker alone, then digoxin is another choice. And most of the previous classical teaching, Manjuran sir, is a patient with a dilated heart, a left ventricular third heart sound, digoxin is helpful who is symptomatic.
Jabir, if the blood pressure is on the lower side, like it's 100 or 100, just start up 100 plus, and when you are given a choice to select ARNI or beta blocker, which one will be the first drug?
I would always prefer a beta blocker first because beta blocker reduces the arrhythmia, prevents a sudden cardiac death. So let the patient be alive. Then we'll add an ARNI. My professor Manjuran sir used to tell, you should not worry too much about the blood pressure. Is he symptomatic? Are there symptoms of low blood pressure? Low cardiac output. If there are no symptoms of low cardiac output or low blood pressure, hypotension, then a blood pressure of 90 if the peripheral pulses are felt, if the extremities are warm, and if he produces a good urine output with normal mentation, you can start vasodilators. And sometimes, once the patient's either vasodilators may improve the cardiac output, his blood pressure may come up. And of course, we have to judicially use the diuretics. Hypovolemia may be another factor that could be contributing to the hypotension. So judiciously, but at the same time, a patient with 80 millimeter blood pressure, you start an ARNI and we are in trouble. And all the ARNI trials have shown that there was an excess, a most important adverse effect is symptomatic hypotension, and that was the reason for termination of the drug also.
How often you escalate the ARNI dosage?
We now escalate, we start with the initial dosage in hospital. By 2 weeks, the first review, they come at 2 weeks, 2 weeks, 4 weeks, and next is 6 weeks. Our ARNI patients, around 30 to 40% of patients could tolerate the maximum dose, 200 milligram twice a day. I have the data because we have a heart failure clinic.
And do you think there is an entity called Lasix crucible resistance?
Yes, of course. That is mostly not in patients who are severely symptomatic, grossly volume overload. They don't respond even to very high doses like 106. If it crosses 160 milligram, then there is no point in further increasing because it's a high ceiling diuretic. We have to add other sequential nephronal blockade drugs.
Okay, thank you, Dr. Jabir. Any questions from the audience? Anything to add?
Many a time when you go for the classical goal-directed therapy, naturally you will not be able to reach all these drugs in the proper dosing. And this is basically due to hypotension, hyperkalemia, or creatinine. How was your, personal experience as far as managing this?
It's two things. If the patient's symptoms improves, addition of SGLT2 inhibitor helps to reduce the dose of diuretic. So we would try to start SGLT2 inhibitor quite early, which gives an additional renal protection, reduces the dose of diuretic. Once we could reduce the dose of diuretics, the blood pressure improves. And when the blood pressure improves, we add ARNI. And if the patient is on a higher dose of diuretic, borderline blood pressure, I may be a little hesitant to start the ARNI, and only slowly we may add the ARNI. And mineralocorticoid receptor antagonist, if the patient potassium is normal and the renal function is normal, our practice is to start ARNI early. Though many of the guidelines recommend that you start, MRA first. You start ARNI, patients who are on ARNI tolerates MRA better. But MRA seems to be a more friendly drug if there is no hyperkalemia. So we always start the MRA first. We start with beta blocker, SGLT2 inhibitor. Add MRA, look at the blood pressure, look at the renal function. And if the blood pressure is stable, no symptoms of hypoperfusion, we add ARNI. And most of our patients at time of discharge will be on either 3 drugs or sometimes even on 4 drugs.
The basic problem apparently will be when cardiologists are not very comfortable when the serum creatinine starts rising. So
we are not much afraid of rise in serum creatinine because majority of the patients, maybe less than 5% goes on with the worsening of renal failure. Rest of the patients, once their heart failure improves, it's all cardiorenal syndromes. If it is type 1 cardiorenal syndrome or type 2 cardiorenal syndrome, once the heart failure improves, the renal function follows. Renal function also improves. But if it is a type 2, type 3 or type 4 cardiorenal syndrome, we take the help of the nephrologist also. Because here, it is not the diuretic alone. There is an intrinsic renal pathology that is creating the problem.
And hyperkalemia. It's a very unfortunate that patiomer and CZ9 are not available.
It's not available with us. And once patiomer also comes, ARNI, patiomer, SGLT2 inhibitor, plus vericiguat, I think that will make the patient bankrupt.
Thank you for the excellent presentations, Dr. Jabir.